This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome, and thank you for joining us. Cardiac System, Part 1.
Hello, welcome to Cardiac Part 1. My name's Tim with 24/7nursetutors.com. Today we're going to talk about information of a cardiac nature. Cardiac means related to or relating to the heart. The heart is the pump of our circulatory system. Venous blood, which is low in oxygen and high in carbon dioxide, enters the right atrium via the superior and inferior vena cava and the coronary sinus. You can think of the atria as primer pumps and reservoirs for the ventricles. Blood passes through the tricuspid valve into the right ventricle. The arterioventricular valves allow for blood flow into the ventricles during ventricular diastole or relaxation. They prevent retrograde blood flow or blood flowing back into the atria during ventricular contraction or systole. Blood passes through the tricuspid valve into the right ventricle. The arterioventricular valves allow for blood flow into the ventricles during ventricular diastole or relaxation. They prevent retrograde blood flow or blood flowing back into the atria during ventricular contraction or systole. During systole, the right ventricle pumps deoxygenated blood into the pulmonary circulation via the right and left pulmonary arteries. Can anyone tell me what is unique about the pulmonary artery? Yes, that's correct. The pulmonary arteries are the only arteries in the body to carry deoxygenated blood. The pulmonary valve, which is one of the semilunar valves, opens when the right ventricle contracts and closes to prevent the backflow of blood into the right ventricle. Blood enters the lungs and passes through the pulmonary system to become high in oxygen and low in carbon dioxide. It then returns to the heart via the 4 pulmonary veins into the left atrium. Blood then passes through the mitral valve into the left ventricle. Ventricular contraction occurs and blood is pumped through the aortic valve into the aorta and is sent into the system circulation. The left side of the heart is a higher pressure system than the right side of the heart, and the left ventricle is stronger than the right ventricle. There are many different types of heart sounds that can be auscultated. We are going to discuss the characteristics of the major categories of heart sounds. As noted, valves that do not close efficiently results in a backflow of blood, and valves that do not open wide enough due to obstruction or narrowing, as in stenosis, will cause abnormal heart sounds. Murmurs are low-frequency, low-intensity sounds. If a murmur occurs at the same time as a pulse beat, it is a systolic murmur. If a murmur does not occur with a pulse beat, it is a diastolic murmur. Murmurs are graded on a scale of 1 to 6. Grade 1 is barely audible. Grade 2 is just easily audible. Grade 3, you can hear well. Grade 4, you can hear very well. Grade 5 is loud but still requires a stethoscope. Grade 6 is so loud you can hear the murmur with the stethoscope just off the chest. Systolic murmurs can be associated with mitral regurgitation, tricuspid regurgitation, aortic stenosis, pulmonary stenosis, intraventricular septal defect, or coarctation of the aorta. Systolic murmurs can be associated with mitral stenosis, tricuspid stenosis, aortic regurgitation, pulmonary regurgitation, or patent ductus arteriosus. Additionally, there are 2 abnormal heart sounds you need to be aware of. S3. This sounds like kin, ta, ki. Kin, ta, ki. It occurs just after S2. S3 is low-pitched and is associated with resistance to ventricular fill due to decreased compliance or increased volume load. It is often heard in congestive heart failure. What side of the stethoscope would you use to hear S3? That's right, the bell, since it is low-pitched. S4, this sounds like Tennessee. Tennessee. It occurs just before S1. S4 is also low-pitched and is associated with ventricular overload and increased diastolic pressure. It is heard in myocardial infarction, pulmonary hypertension, stenotic valvular disease, hyperthyroidism, and also in heart failure. Again, the best advice for heart sounds is practice. If you come across a documented heart sound in one of your patients, take time to grab your stethoscope and have a listen. Ejection fraction is a measurement of the percentage of blood leaving your heart each time it contracts. During each heartbeat, the heart contracts and relaxes. When it contracts, it ejects blood from the ventricles. When it relaxes, the ventricles refill with blood. No matter how forceful the contraction, the heart is not able to pump all of the blood out of a ventricle. The ejection fraction is the percentage of blood that's pumped out of a filled ventricle with each heartbeat. The ejection fraction may decrease in cardiomyopathy, myocardial infarction, valvular disease, and uncontrolled hypertension. Ejection fraction can be measured with the following diagnostic methods: echocardiogram, cardiac catheterization, an MRI, a CT scan, and nuclear imaging. There are a couple of categories of heart failure related to ejection fraction. Heart failure with preserved left ventricular function, the ejection fraction is in the normal range because the left ventricle is still pumping properly. Heart failure with reduced left ventricular function, the ejection fraction is below the normal range because the left ventricle is not pumping properly. All right. Let's cover some key terms related to cardiac performance and measurement. Cardiac output is the amount of blood ejected by the left ventricle in 1 minute. Cardiac output equals heart rate times stroke volume. Stroke volume is the amount of blood ejected with each beat. Normal stroke volume for an adult is about 60 to 80 milliliters. Can anyone tell me what the normal heart rate for an adult is? That's right, 60 to 100 beats per minute. So what is normal cardiac output? Normal cardiac output is 4 to 8 liters per minute. Think of the ventricle loading up with blood before its next big push. This is preload. It is the amount of tension in the ventricle at the end of diastole. It is measured as left ventricular end diastolic pressure. You could also think of a balloon as an example. The more air you blow in the balloon, the more it stretches. Afterload is the amount of resistance the heart must overcome to open the aortic valve and push the blood out. Afterload is measured as systemic vascular resistance. Cardiac reserve is the difference between the amount of blood the heart is able to pump under normal circumstances and its maximum capacity to pump blood. It can also be expressed as the ability of myocardial muscle to stretch under normal circumstances compared to their maximum capacity to stretch. Think of a rubber band. What happens when you stretch it and snap it against your arm? Yeah, the more you stretch it, the harder it strikes, and the more it hurts. This essentially is a representation of Starling's law of the heart. Starling's law of the heart states that stroke volume of the heart increases as there is an increase in the volume of blood filling the heart when all other factors remain constant. This increase will cause an increase in ventricular contraction and volume of blood being ejected. I was working in a clinic early in my career, and I was examining a middle-aged patient named David, who had been complaining of general weakness and shortness of breath. I checked his vital signs. His pulse rate, by my calculations, was a little high, 98, but within the normal limits, and his pulse felt a little weak. His blood pressure was 102/50, which was a little low for him compared to previous measurements from earlier visits. When his primary physician examined him and auscultated his heart, he came up with a heart rate of 132. There you have it in action. Pulse deficit. A pulse deficit is when the palpable pulse is less than the actual heart rate. This means that even though the heart is contracting, some of the contractions are not strong enough for a pulse to reach the periphery. Pulse pressure is simply the difference between the systolic blood pressure and diastolic blood pressure. Pulse pressure, the SPB, to DPB. Normal pulse pressure is 30 to 40 milligrams of mercury. A common reason for a narrow pulse pressure is blood loss, often due to trauma. This requires immediate resuscitation. A wide pulse pressure occurs when there is increased resistance, such as atherosclerosis or aortic regurgitation. Please look at the picture on the screen as we talk about coronary circulation. The coronary arteries branch off at the base of the aorta. There is the right coronary artery, which supplies the right atrium and right ventricle. There is the left coronary artery, which branches into the circumflex artery and the left anterior descending artery. The left anterior descending artery supplies the anterior wall of the left ventricle, and there is also the circumflex artery, which supplies the posterior portion of the left ventricle. The left anterior descending artery also has a rather morbid nickname. Do you know what this is? That is correct. You might hear this called the Widowmaker. Do you know why it might have this nickname? Right again. Think about what area of the heart the LAD supplies. It supplies the left ventricle. A blockage high on the left anterior descending artery or left coronary can cause a total or near total failure of the front wall of the heart. This type of myocardial infarction or heart attack can have severe or fatal consequences. Technically, this is called a proximal LAD lesion. Hey, what do you say? Let's make this easy. The heart receives blood flow from the coronary arteries and veins, which lie superficially on the heart surface and penetrate the muscular heart layer, the myocardium. The arteries branch from the aorta and surround the heart surface like a crown. Now, as mentioned in the last slide, the left coronary artery supplies the anterior and left lateral portions of the left ventricle. The right coronary arteries supplies most of the right ventricle and the posterior side of the left ventricle. Since the heart receives its blood from right off of the aorta, this blood is highly oxygenated. The heart is a very aerobic organ. The coronary circulation is autoregulated so that the heart receives the right flow of blood and a sufficient oxygen supply. Typically, coronary blood is about 4 to 5% of the total cardiac output. Now, if a resistance to coronary circulation becomes present, then the coronary perfusion pressure, the CPP, increases proportionally to maintain the same flow. This way, the same flow through the coronary circulation is maintained over a range of pressures. This part of the coronary circulatory system is known as autoregulation. Local arteriolar vasodilation is the main controller of coronary blood flow. Whenever the heart activity is increased, the rate of coronary flow is also increased. This also applies to decreased activity. The blood flow is slowed down. Coronary blood flow is regulated in proportion of oxygen demand for the cardiac muscle. If the heart needs more oxygen, then the coronary blood flow must be increased. If there's a decrease in oxygen supply to the heart, it is speculated that vasodilation occurs due to substances from the muscle cells being released so that the arterioles dilate. Before we further discuss the type of heart sounds and murmurs, let's look at how you listen for them. You will use your stethoscope and you will use both the bell and the diaphragm to listen with. I recommend a high-quality stethoscope to really be able to hear these sounds well. The bell of the stethoscope is used to hear low-pitched sounds, S3, S4, and murmurs associated with ventricular filling. The diaphragm is used to hear high-pitched sounds, S1, S2, ejection clicks, opening snaps, and murmurs due to stenosis. Also for these, practice makes perfect. Again, take the time to listen and listen carefully. If you know a patient has a documented abnormal heart sound, use your stethoscope and listen. There are 5 key locations for the osculation of heart sounds: the aortic area, the pulmonary area, Erb's point, the tricuspid area, the mitral area or apex. A mnemonic many of my students have used is ape to man. Yes, I'll say that again. Ape to man. A, the aortic area. P, the pulmonary area. E, Erb's point. T, the tricuspid area. And M, the mitral area or apex. Take time to locate and listen to all of these locations with both the bell and diaphragm. There are many websites now available with sample audio files for both normal and abnormal heart sounds, but nothing can take the place of listening for them on a patient. Normal heart sounds are caused by the closure of the heart valves. This is the typical lub-dub you think of when you think of the sound of a heart beating. The first sound, lub or S1, is caused by the closure of the AV valves. The dub or S2 is caused by the closure of the semilunar valves. Both S1 and S2 are best heard with the diaphragm of the stethoscope. Remind me, which valves are the AV valves? That's right. The mitral valve is on the left and the tricuspid valve is on the right. Okay, so which are the semilunar valves? Yes, the right one is the pulmonary valve and the left one is the aortic valve. Going back to the previous slide, where do you think you would best hear murmurs for the tricuspid valve? The aortic valve. That's right. It's pretty obvious, isn't it? You would listen for sounds associated with these valves in the area associated with these valves. Heart sound should be evaluated for pitch, intensity, duration, and quality. Tell me, what is another name for hypertension? The silent killer. Please tell me, why is hypertension called the silent killer? Hypertension is also known as the silent killer because patients have no symptoms to alert them to the elevated pressure. However, hypertension leads to other diseases such as stroke, congestive heart failure, heart attack, and kidney failure. A few months ago, I was working in the pre-op screening area for same-day surgery. I had a patient that had come in for a vasectomy. As usual, I checked his blood pressure. At first, I couldn't find the systolic pressure, but I was hearing something around 110 that was very strong. I pumped the cuff higher and got a reading of 240/100. I thought, I had an anesthesiologist that was working with me double check this, and he confirmed my findings. Needless to say, this patient's surgery was canceled for the day, and the anesthesiologist spent a bit of time getting this patient's blood pressure under control. Would you believe that patient was totally unaware that he had hypertension? Hypertension is defined as a persistent elevated blood pressure of 140/90 millimeters of mercury. Some medications used for hypertension include beta blockers, ACE inhibitors, and calcium channel blockers. What are some non-modifiable risk factors? Well, gender, genetics, ethnicity all contribute to the potential for hypertension. What ethnic group? African Americans. Male or female? Male. Like all cardiac illnesses, a healthy lifestyle can prevent hypertension. What are some modifiable risk factors? Smoking, alcohol use, and a sedentary lifestyle. Tell me, class, what brings patients on ACE inhibitors to the ER? Angioedema and a cough. Remember, you are more than a conqueror, and you will be successful. Join me as we review core content in the next unit.